Hello everyone, thank you very much for joining us today. We are creating this video to illustrate with you a few of the points associated with sacroiliac joint inflammation or sacroiliitis, and that's to help you perform and execute the physical examination maneuvers correctly at the clinic to increase the accuracy of your diagnosis. To help us create this video, we are lucky to have Susie, who volunteered to help us establish the diagnosis or increase the likelihood of the sacroiliitis diagnosis. So initially, I will show you where the pain is most likely going to be. So let's assume for a second that Susie has right-sided sacroiliitis. Typically, patients will describe the pain in this area, which is just inferior to the waistline and a little bit lateral to the midline. And typically, the pain will be in this area here, but it can also radiate on the posterior aspect of the thigh to maybe about the knee level. It can also radiate anteriorly to the groin. The first physical maneuver to increase your likelihood of the diagnosis of sacroiliitis is called the Faber test. And in that test, you ask the patient to make the figure 4 with their leg. And basically, Faber stands for flexion, abduction, and external rotation. So when the patient has performed this figure 4 maneuver, you apply pressure on one knee and pressure on the contralateral side over the iliac spine to basically stabilize the hip. And then you apply pressure, downward pressure over the knee while observing the patient's face. Now, with this exam, if the patient complains of anterior pain, that might be suggestive of hip arthritis. However, if the patient tells you the pain is in the back where you would expect the sacroiliac joint to be, then that is a positive diagnostic test. If you're suspecting hip arthritis, I will ask the patient to straighten her leg again, and then I will do external rotation of the leg. At this point, if the patient tells me the pain is actually in the front, then we're most likely dealing with hip arthritis. The second exam to test for sacroiliitis is called the thigh thrust exam, in which case the patient is asked to flex the hip and the knee at a 90 degrees angle. Then you apply downward pressure while observing the patient's face. And if the patient complains of pain, again on the backside where you would expect the sacroiliac joint to be, then that's also another diagnostic positive test. Another test for the sacroiliac joint is known as the distraction test, in which case you are trying to apply an outward pressure or force by placing your hand over the anterior iliac spine and pushing outwards. If the patient complains of pain again in the back where you expect the sacroiliac joint to be, then that's another positive test. The last test I'm going to talk about is called the compression test, in which case the patient lies on their side and you try to apply downward pressure in this area. And if the patient complains of posterior back pain, then that also is diagnostic of the sacroiliitis. The gold standard test is actually injecting local anesthetic under fluoroscopy guidance in the sacroiliac joint. If the patient experiences pain relief for the duration that you would expect, depending on the local anesthetic agent, then this is the gold standard test. However, this is not always possible in an office setting if you do not have fluoroscopy equipment. Another thing to be mindful of is before you apply pressure to the knee, always ask the patient if it's okay to do so, because many patients have knee pain and it can really be distracting while doing the exam itself. Thank you. During the last 4 minutes or so, we attempted to share with you the most common presentations for sacroiliitis and the most common physical exams for it. However, it is important to mention that some patients may have different presentations, so it is crucial to get a good history to develop a differential diagnosis. It is also worth mentioning that some patients may have unusual presentations for their pathologies. For example, their pain may not follow a dermatomal trajectory, or the pain may not be at the anatomical location for a major joint. Therefore, It may serve your patients well to widen the differential diagnosis and consider other sources of pain. For example, skin, muscles, ligaments, tendons, or fascial layers may be other sources of pain. It is also important when you examine a patient with unusual history, presentation, and a physical examination which does not support your hypothesis to take a step back. It is tempting to reinterpret the data to fit the presentation, but it's better to look at another explanation to fit the evidence. When all else fails and there are no possible organic sources of pain, it may be time to consider consultations with other specialists to rule out psychiatric contribution, which may cloud the picture. Measure twice, cut once.